Today, we're going to talk about one of the most polarizing and critical pillars of public health, harm reduction.
In the world of street medicine outreach, we have to navigate abstinence versus NARCAN or education versus criticism. It's truly about keeping people alive long enough to make a different choice tomorrow.
All right, so we're going to ask and answer 3 questions. Number 1, can traditional harm reduction models stand up to a drug as fast-moving as fentanyl? What is the margin of error for street outreach workers? And finally, and most importantly, there's a growing debate about whether harm reduction is actually enabling people. So we're going to answer that question too. Welcome
to Untangling Knots. This is episode 11, harm reduction.
Here we go.
All right, let's go.
Harm reduction right now is, for those who don't know.
Yeah, let's educate what harm reduction is.
And I had to learn too. When you get in this field, you have to learn. And this was back in 2009, 2008. So harm reduction looked a little different, although the principles of harm reduction remain the same. So I think, though, because your team actually trains people, teaches people about harm reduction, you should probably educate them. You're going to be better at that. Educating folks. So will you let them know?
Sure. So harm reduction is not encouraging people to use drugs.
Right. It was.
I know. A lot of people think that, but harm reduction is really giving people tools so that they can get through and maybe, as I just said, make a different choice. It is keeping people alive. It is reducing the risk of diseases that occur when people use dirty needles and use dirty drug paraphernalia. Here's the thing that what we know when we're talking about our patient population, people who have substance use disorder. If I walk into someone and I say, you need to stop using drugs and point my finger at them as a medical provider.
Does that work?
No, they're going to turn around and walk out. I'm going to actually give you an excellent example of this. Last night in clinic, I had a guy, 47 years old with congestive heart failure. And I said, when was the last time you used meth? Number 1, I didn't say, do you use, right? It's okay. That's opening it up to know, like, I just want to know. And he said, well, I last used 2 weeks ago because they told me about my congestive heart failure. And I said, did they tell you why you shouldn't use meth if you have congestive heart failure? No. And so I sat there and explained to him the effect of the drugs on your heart, of meth and cocaine and fentanyl on your heart. And he said, I didn't know any of this.
Of course.
Right? So I didn't point my finger at him and say, you need to stop using drugs, because we all know, like, we're all in it now. We've been hearing since the 80s that drugs are bad and you shouldn't do them. We got that. We got that memo. The problem is as medical providers, we do not want people using drugs. Obviously, there are so many adverse effects on the body that people don't even recognize. Like him, he's like, I didn't know it did that to my heart. Now, common sense would say, oh, why wouldn't you know that? But people don't know that. They truly do.
Everyone's starting point is different.
Exactly. And so what we try to do, and I've said this over and over on this podcast, and I'm going to keep saying it, is we meet people where they are. That means physically and emotionally. So if I walk into an encampment, because remember, I'm a street medicine provider, right? If I walk into an encampment and I'm like, oh, you're doing drugs, you need to stop, I am never going to be allowed to come back to that.
They don't want to hear it.
They don't want to hear it. They know that. They know drugs are bad. But if I can say, like, what are you using? Do you know that a lot of times that has fentanyl in it, or that has some other meds, drugs mixed in? They'll be like, no, I didn't know that. Well, can I give you a test strip to see if there's fentanyl in your drugs? Because
that's the point of harm reduction is if someone's going to do a risky behavior, let's remove as much risk as possible if they're not going to stop doing that behavior.
So some of the harm reduction tools that are used, and not necessarily by us, and I'll give you this caveat, because
just in general.
So there are needle exchange programs. We do not do that because it's illegal in Missouri and Kansas. But in other states, it is legal.
We'll talk about why it is illegal. There's a huge debate about harm reduction, and that's part of it.
Sure. But in some states, it is legal. And that harm reduction is reducing the risk of dirty needles being used. Now, some people would say, well, why did somebody use a dirty needle? Well, because you have a substance use disorder. There's a needle on the ground.
If you're asking that question, understanding what substance use disorder is and does is really important here.
Exactly.
It tells you, I need that. The need for the substance is going to outweigh the risk.
Exactly, because you get really sick
Yes.
when you're withdrawing. Okay, so So there's needle exchange programs. There are also in some states what's called safe use sites.
Oh yeah.
Also not legal in the Midwest. I don't think it's legal anywhere in the Midwest.
Scandinavian countries, there's one, I gotta look it up. They have one. There is a
there are a couple in the United States.
I believe in Amsterdam as well. Look, there's growing research around these. We can get into it in a bit.
Yep. So what those are places where people can go and use drugs safely in a controlled environment.
It's lab drugs. There's no adulterants in them. They are, it's pure. No one's going to overdose because they're going to control the amount that they give you. Look, this is unfathomable to us in the Midwest.
Right.
But this is a tool in the fight against substitutes.
And then we also have naloxone or NARCAN, which reverses the effect of the drugs, fentanyl, and it reverses the effect of the opiates. Right. So
there's no side effect. There's no downside for folks carrying it with.
No, there's no downside to folks carrying it. However, people who have been reversed with Narcan hate it.
Oh, they get mad.
It's rough. No, but it's also rough. It is rough to be Narcaned. But the argument is, well, is it rougher than being dead?
Well, it's a harm reduction.
It is a harm reduction. So it's not about the comfort. It's about keeping you alive another day.
And look, this statement is simple. If you're dead, you can't get clean. Okay? So, like, harm reduction is a tool to keep people alive to make a better decision later.
What we know about people who are living on the streets is that they are still young and have the chance to be productive members of society.
And we believe in them.
Absolutely, we do believe in them. And we believe that people have a chance to get back and get to where it is they want to be in life.
Yes.
Most of the people that we take care of do not want to be on the streets. They do not want to be using drugs, but they've gotten there a variety of ways. And it's not our place to judge or to say like, oh, well, you shouldn't be here. Captain Obvious.
Look, if they could push a button and not have, 100% of the folks I've worked with would push that button and not have substance use disorder.
Exactly.
Everyone. They don't want this. This isn't the life they wanted.
No. And so people who are opposing this are going to say, well, they continue to use drugs. Yes, because detox centers are few and far between.
We're going to go
rehab centers, right?
In a white knuckle.
Yeah, exactly. And rehab centers, they're very difficult to get into if you can get into them at all, particularly if you don't have insurance. And then we've talked about this before. Going back, you get out of a rehab center. So say you're there for 30 days, right? Where do you go? Because you came from the streets.
Guess where you're going to go?
You're going to go back to the streets. And the streets are really rough.
And the dope man's going to come by.
Exactly. And what we know from our people who have had substance use disorder and who have, overcome that, gotten past it, you never get past it. So it's literally one day at a time. I have patients who have been off the streets, who have been off of substances for years, and they say there are still times that they think about it. So it's constant. And so if you're living outside in wherever you are and it is freezing cold and someone's like, I got something to warm you up, and you just got beat up because you had your backpack, and
regardless of why,
it doesn't, but things get rough and you're like, okay, why am I even trying? What's the point? And it becomes a vicious cycle.
And people everyone has felt that. Why try?
Right.
Imagine that magnified. That's what it is. So it's easy for someone without substance use disorder to say, just quit. Sure. I promise you they would if they could.
Absolutely.
It's very, very difficult. So there's an aspect of harm reduction that can be considered controversial. They're called wet houses. Mm-hmm. This is I remember hearing about these. So like when you come up in the world of homeless services, there's kind of two tracks that you can go down. One of the tracks is the faith community, and that's the abstinence only track. The other track is the harm reduction track, which is a little more grounded in reality, and certainly the reality of substance use disorder. Right. The issue I think a lot of people have is, does the harm reduction track go too far and enable people? And one of the areas that there are complaints are wet houses. Here's what wet houses are. So if you have substance use disorder and alcohol is a drug of choice, If you quit cold turkey, you might die.
Yeah.
It is among the most dangerous
Very
things.
dangerous.
Yes, I'm sure you have
Yes.
seen this your entire career.
Yep.
You can have a seizure. Quitting cold turkey is not a good idea.
When we have people who are just using alcohol and drinking large amounts of alcohol, they're like, I want to get off the alcohol. I want to quit. We encourage them to go into a hospital.
Yes.
There is a protocol in every hospital.
Yes.
For withdrawal from alcohol, and because of the risk, seizures, death. I mean, alcohol withdrawal can be fatal.
So wet houses exist as a place to monitor and control the amount of alcohol being taken in without having someone have to quit cold turkey. So it's like a stair step. Like, the patch with cigarette, that is a harm reduction tool.
Right.
You're still getting nicotine, but you're stair stepping down from the amount. It's the same thing with wet house. You go in there, you literally live there, and a couple times a day, whatever the recommended dose is for you, because it's going to be different for everyone,
Right.
They're going to give you a beer. They're going to give you a drink of some kind up to a certain amount. Everyone is different. But that's how folks get to it. And it's less and less and less and less. And by the end, they're not going to withdraw and risk dying from it. And there are a lot of people who, for some reason, think abstinence is the only thing that people should do. And I simply don't understand where this is coming from, except the context of many or most Americans coming up in a religious background and being told alcohol is evil, drugs are evil, it's a no from the start, they're bad people, so you should just stop cold turkey. And that mindset is really destructive, especially for folks who are actually in the throes of this. Yes, there are some stellar exceptions of people who white-knuckled it, but those are rare. We can't build a system around exceptions. You have to build it around what the rule is. And the rule of substance use disorder is harm reduction can be really helpful.
Absolutely. I mean, we know that. We know that lives are being saved based on harm reduction. So when we talk about Narcan used to be so expensive. You couldn't get it because it was so expensive. And a few years ago, it became much more available. And we actually, 2023, I think, we put the first Narcan dispense boxes throughout the metro. We put like 35 out, put Narcan in it because we were able to get it. Numbers from the city are showing the impact of having Narcan. So I just got a report from the Kansas City Police Department about November numbers. Last year, so this is 2026 now.
Yes.
Last year, 2025 in November, the number of suspected overdoses were cut in half.
That's
half,
good.
Right? And it has a direct correlation to the availability of Narcan. It has a direct correlation to people being educated on the Narcan use. And it's not because less people are using drugs. It's safer use. But the thing is, here's where people are like, okay, so you just give them Narcan and then they go out and do it again. It's not quite like that. Because when you do that Narcan education is the key. Like providing a little bit of information about cessation, about going into a rehab, about working on long-term housing solutions, about, okay, what do you want? Where is it you want to be? So, like if you just hear us talking about like, oh, well, 24 people were suspected to have overdosed in 2024, November of 2024 in Kansas City, whereas only 12 in November of 2025. So how many of them then overdosed in December? It's not like that. It's providing education, providing resources, providing a connection to people that says, hey, look, we're going to do this now because we know that saying to you drugs are bad and you need to quit is not the answer. You do need to quit. Like, I want to make sure.
Is simply just keeping you alive isn't going to do it either.
Exactly. I want to make sure that people understand that we're not condoning substance use.
No.
We're not
0% that.
But we're trying to figure out how to work to walk hand in hand with the people that we're serving in order to get them where it is they want to be in their journey. And as you said, I haven't met anybody who's like, I just want to use drugs for the rest of my life. It doesn't work that way. They don't. But they don't know how to get out. Maybe they've tried. Most of my patients who have a substance use disorder have been to rehabs numerous times.
Yes.
Right. So what is it this time? What can we do? What can we help you with? And the very important piece of that is this time, because you know what? We're going to come back to you, come back to you, come back to you. We're going to continue to be there for you every single time. You know what? If you didn't quite do it this time, next time.
Well, now we got to talk about the criticisms.
Yeah.
Because there are certain criticisms that I think are out of bounds, in as much as they can be. People are allowed to have their opinion. Some of them, though, and here's what we got to talk about. One of the things that happens in the world of homeless services is people in this field love to excuse behavior. They love to do it. They often think because someone's experiencing homelessness, they are exempt from consequences. And what we often do in homeless services is we treat homelessness like the only person being impacted is the person experiencing it. The general public does not feel this way at all, not even close. And I think it is and has been irresponsible of homeless services to take that posture. Because substance use disorder means substances, and you got to get them from someone.
Yep.
So they don't just grow. Well, they do somewhere. They don't grow them here.
Sometimes they're manufactured around here, but that's a whole other subject.
But that element then is introduced. The other element that's introduced with substance use disorder is when you're jonesing, you behave a certain way, and when you're on substance, you behave a certain way. Yeah. So the general public is saying, look, why are we allowing this to happen more and more? Doesn't NARCAN or Narcan, doesn't it just encourage people to use? And here's what I'll say. There are absolutely situations where folks with opiate use disorder, I don't know if that's the right term.
It's substance use disorder.
We'll just keep it at that.
Yeah.
What they'll do is they will get Narcan, they will bring it to their encampment, they will use to a point, and they'll Narcan up, and they're using it as a way to mitigate death, but they just want to use it.
That's rare, though.
That's so rare.
Does that
happen?
Rare.
Yeah, sure. It absolutely happens.
But well, can I say something? Tell me the difference between that and a diabetic, an insulin-dependent diabetic who eats too much cake and candy and gives himself a little extra insulin. Tell me the difference.
Because what's it called? Fentanyl means fentanyl dealers. Fentanyl means crime. Fentanyl. Look, I get it. I understand that
from a medical standpoint.
Yeah, but the general public ain't gonna see it.
I know.
And I'm on the general public side on that analogy. Now, I get it, but I also understand, look, fentanyl really forced the harm reduction conversation to change, and it needed to change.
Sure, absolutely.
Because I remember coming up in this field, harm reduction essentially became a catch-all to excuse every behavior possible, because that's our only job, is to affirm people in their bad choices. This was really like, you have zero judgment. You can't. It's like, no. As a case manager, you are paid to have better judgment than your client at that time, because they need you to have that. It is your job.
That absolutely.
But here's the deal: you are not paid to judge them.
Right.
It's not effective. What you're paid to do is be reliable. If you're reliable, you will form a relationship, and it is through relationships overwhelmingly that folks choose to end their substance use dependency. Overwhelmingly, it is relationships.
It's just like me having that conversation last night with my patient and saying, do you know, like, I'm really glad that you haven't used any meth in 2 weeks. I'm really glad. Do you know why it's important that you continue for your heart? I mean, and I wasn't going into all of the other reasons. Sure. Because right then we were talking.
He knows the other reasons.
Well, right. But does he? I mean, he didn't know about his heart. And I'm going to tell you, we have a lot of
He knows it ain't great.
No, they know it's not great. I have a lot of patients with congestive heart failure. Anybody who does street medicine does.
Certainly.
And they're young. And every single time I have this conversation about congestive heart failure and street drugs, people are like, well, I didn't know that. The cardiologist told me I just needed to stop using. Well, yeah. I mean, any medical professional, we're all going to say, my answer is you need to stop. But let's talk about this a little bit more.
Yeah, talk about how to stop.
Exactly, and how to stop. I think that that's very, very important. I want to talk a little bit about medications used, medication-assisted treatment.
That's great.
MOUD. So medication-assisted treatment is MAT, and MOUD is medication for opioid use disorder.
Awesome.
Now, I generally say MAT. MOUD is more oftenly used for fentanyl, but the problem is, at least here in Kansas City, we have such a huge issue with methamphetamine use that the drug of choice is not fentanyl overwhelmingly. Yes, there's fentanyl in everything, but it's mixed in with the meth, and meth is
Meth's a hit.
It is. So, but when we were doing medication assisted treatment 5 years ago, it was okay. Well, you have to come in. You have to do a UA. If your UA is positive for any drugs, you can't get your medications. Okay, I'm going back here to my insulin dependent diabetic. Yes. And I know you don't like this analogy, but this one is even stronger. If you have a diabetic who comes into your clinic and their blood sugar's 450 and their A1C is 10, that's abnormal, by the way.
We don't know what that is.
No, I know. So that's abnormal. A normal blood sugar should be below 120.
So way higher.
Way higher. And a normal A1C is 5.5. Okay. So if that person comes into your clinic and their blood sugar is that high and their A1C is high, do you say to them, I'm not going to give you your insulin because you're eating sugar? No, you prescribe that. Yeah. But if a person comes into your clinic and they have drugs in their system, you don't give them the medication that can help them overcome that. It makes no sense, right? So we have.
So this is what happens when the rules around a thing have been created by non-medical people.
Yeah, so
overwhelmed.
I will tell you though, in MAT treatment, that is changing. That is changing. It's okay. Well.
So it's no punishment.
No, you can't. And if you can walk alongside people, you're going to get better results for them 100%. And for the environment.
Because you're building a relationship.
Exactly. And I think it's really important that people understand that. Like, I think, as you said, people see it as enabling, and it's not. It's not at all. We're not giving them drugs at all. But we're trying to work with them to get them out of being afraid to talk, out of being afraid to seek treatment, to seek help. It's progressive engagement, which you and I have talked about numerous times on this podcast. Progressive engagement works, whether it's with an outreach worker or a medical professional. It's
just means showing up,
over and being over consistent, and saying to them, "Are you ready to stop? Because we're here."
And it's interesting, kind of the pushback on harm reduction. It almost always falls on the outreach worker to be a million different things. Outreach workers have to be law enforcement. They have to be a medical professional. They have to be a counselor. And now they have to respond to a community saying you're enabling. An outreach worker's job is to help get someone out of homelessness. Part of getting someone out of homelessness, is if they have a substance use disorder, it's really hard to house them.
Yeah.
Really hard.
It is.
It's also really hard to get them out of homelessness if they're dead. So an outreach worker has a niche, a pretty narrow niche, a very difficult and dense niche. It's one of the hardest jobs that you can have in this field. But here's the deal, expecting an outreach worker to also respond to a community saying you're enabling them, they can't think that way.
No.
You cannot like harm reduction. Don't blame the outreach worker.
No.
Their job, they want that person to stay alive because they want to get that person help. That is what they're going to do, and they're not going to stop doing it. So the pressure on harm reduction, and I get it, I understand. I understand believing that NARCAN allows people to use more fentanyl. And on its face, that is a factual statement. But it is absolutely antithetical to the spirit of helping someone.
It is. It's way deeper than that.
It's
like, we've all seen the analogy of the iceberg underneath the water. It's you see a little bit on top, and yes, at the surface, you're right. If I give you Narcan, then you can go get more fentanyl.
Yeah.
But you're not dead. And
that's what we're thinking about.
We're thinking about, are they dead? And me giving them that Narcan has opened a door. It has opened a communication door, a lifeline potentially for them, a trust line.
And the element of, we actually think you can do it.
Yeah.
Folks that are saying no harm reduction, They have no belief in the folks that we're working with.
But because we've seen it. We have seen
We
it.
will
We've
never,
seen it.
there's never going to be a moment where we say this person, it's impossible.
Yeah.
Why? You can't be in this field if you think that, get the hell out.
Yeah.
I have no time for you.
No,
we will never think that.
No.
So like the opponents of harm reduction, what you're telling a group of people is to be a thing that we can never be.
Right.
We will never give up on them.
No.
It's not going to happen.
No. And again, I hear the arguments, and I can understand the arguments, but if you get in the work,
you'll change your mind.
You'll change your mind.
I promise you, you will change your mind.
Absolutely, 100%.
Yeah, look, harm reduction had to shift around fentanyl because fentanyl is a pretty fast-acting substance.
And deadly.
And very deadly.
Very deadly.
And look, we're new at this. So to say, oh, harm reduction doesn't work. This is relatively new, figuring out how to navigate this type of drug. But what we're seeing over time is there's some success that's happening.
And I think that, like the numbers that I gave you from the state and from
that's something.
This KCKD, I think no matter what state you're in, you can get those numbers and you can see what has happened over the past 3 to 5 years, really since NARCAN became more widely available, and see that those numbers are reducing. And I think that what we also know is that if we can get people to come to a place where they want to be off of the drugs, we're going to have a better chance of getting them housed, getting them jobs, getting them as productive members of society.
Yes. I think we all want the same thing. Now,
absolutely.
I think what the general public's worried about is that if the data is telling you something different, that the World of Homeless Services is going to ignore it. And this is where I understand the general public's frustration. Because the World of Homeless Services has a really hard time with reality sometimes, especially around the housing first movement. So I think that baggage is connected to harm reduction.
Yeah.
Where we're not going to change course. This is the only way, and it becomes an ideology. I understand that. We're still learning a lot about medically assisted treatment. We're also learning a ton about harm reduction around fentanyl. Give us time.
Yeah.
The data we have to
get more data.
Yeah,
for sure.
And we do.
I think, even like current HUD guidelines, we talked about HUD a little bit a few podcasts ago, and the current guidelines, whatever. The current HUD guidelines are supportive of NARCAN, naloxone education, not of needle exchanges, or not of fentanyl test strips, and not of safe use sites, but of NARCAN. And I think one of the reasons for that is because numbers don't lie.
Yes.
The data is not lying about what's happening in the United States since we have had better access to NARCAN.
That's it.
All right. Now it's time for your favorite part.
We were going to ask you.
So we have asked the experts. We're missing our
Asker,
Jackie. She's off for a couple weeks. So we're going to try to wing this.
Muddle through this.
Do you have a question?
Yeah, but I'm just going to ask you a question.
Okay.
This go around.
We're not going to ask you a question?
I don't think we'll have time. Well, ask me on the next one.
Okay.
That'll be good. Okay. You have been in this field. You've kind of pioneered in Kansas City what street medicine is. What have you seen change around harm reduction since you started?
Okay. A couple of things have changed in the landscape of our patients who are living outside. So I want to get to your question, but I do want to say one thing that I've noticed. In the last 10 years, we used to have a lot of people outside that were solely drinking alcohol, right?
Yeah.
Alcohol use disorder. I can't think of anybody right now that's just strictly alcohol use disorder.
What a fantastic observation.
Yeah, and I don't have numbers to support that, but but we talk about that. Like, we used to have a lot of camps that were just people out drinking whiskey and vodka. We don't see that anymore. Everybody that we see that has an alcohol use disorder has a coexisting substance use disorder. Okay, so I think that's interesting. I don't know what to think about it, but I do think it's interesting and a little bit scary.
Yeah.
Okay, so a couple of things. NARCAN availability. When we first started doing street medicine, we didn't have any NARCAN. And then a couple of years into it, we got some IM NARCAN that we used. I don't know if people know the availability. You can give it IV, IM, or intranasally, which
Yes.
is really what a lot of people mainstream know about it. I mean, even like if you now a lot of times if you get a prescription for a narcotic post-operatively, they also prescribe Narcan.
Oh yeah,
which is interesting. Never happened before, right?
That's true.
Just in the last.
It's in my house right now. When my mom got prescribed
exactly.
Yes.
Yeah. So, but on the streets, like at first we just had IV, and I am IV. I actually started an IV a couple times and gave some IV Narcan and watched it work. But now having the availability of intranasal Narcan has been a game changer. Now, I have met some people who have a history of substance use disorder and are doing the work. They do like needle exchange and Narcan, and they do they help people get new rigs to use. Rigs, yeah. And sometimes it's bubblers and things like that. Look that up. And they don't like Narcan at all. They don't like the nasal Narcan. Let me come back to that because they feel like it's too harsh, and it is very harsh. I'm not saying it's not.
Oh, it's like getting the paddle.
It is.
Yeah.
But it's also not death.
Oh, yeah.
And it's really difficult. We tried to train people when we first had the availability of injectable Narcan. We tried to train people how to give that, and that didn't work. Even giving it IM, it didn't work on training people. So our thought is a bad wake up is better than a death.
Yeah.
I mean, and I don't mean to be a smartass about it, but
that seems pretty.
But that does open a few more doors if we can get somebody back and potentially work with them a little bit. So we did, we hear that that no, we don't like the Narcan. There actually was 8 milligram Narcan for a while. I don't know if that's still available. We had it because that's all we could get from one of our international suppliers, and people hated it because 8 milligrams is a lot.
That's
now,
fun, yeah.
Narcan, as you said, is not. It's not a danger to giving it. The wake up is rough, and it's also
uncomfortable to say the least.
The other thing that we train people and our volunteers and our staff and the people on the streets, we educate them. We're like, hey, do you want some Narcan? Sometimes people who we don't know very well will say, I don't need it. And we'll say, how about for 8 of your friends in your camp? Oh, okay. Yeah.
Yes.
And so I think that taking that approach is very, very, being very mindful of where they are and also create some bridges. And
it's a harm reduction tool.
It is a harm reduction
tool. Thing.
So I think that, having Narcan naloxone available has really changed the landscape and helped. The thing is, it has opened up conversations, and opening up those conversations build bridges.
I agree.
Yeah. Awesome. All right. So that's it for episode 11 of Untangling Knots.
Really good.
Join us next time on Untangling Knots, where we're going to continue to explore the challenging realities of homelessness without the sugarcoat.
Happy birthday.